Good afternoon. I will introduce to you this next conference given by Dr. Ballaz, head of the Physical Activity Department of UCAM. His research interests regard the study of walking and posture efficiency for children with neuromuscular or neurological diseases. His research highlighted positive effects of walking and gait and posture. He's the head of the Marie-Enfant CHU Saint-Justin Rehabilitation Center. He wants to collect the biggest database on walking for children in combination with local video game design companies. He wants to design dynamic postural softwares. He's supported by the Quebec government. His conference is aquafitness effects on motor functioning for Steinhert patients. Thank you. It's a pleasure to be with you today to talk about preliminary results of a research project that deals with aquafitness effects on motor functioning for Steinhert patients. Part of this relates directly to aquafitness, but also regards quantified analysis of walking. And we benefit from these people also because we also link their data to walking posture and muscular strength. This research is the fruit of a collaboration between the Lucie Bruno Rehab Center and Saint-Justin Lab. The Saint-Justin Lab is at Marie-Enfant. We conducted a project on aquatic training in pediatrics a few years ago, and we wanted to pursue with adult aquatic fitness because they are dedicated trainers for neuromuscular diseases. Very quickly on DM1, it was done very well in the previous presentations. As you know, it's a rare neuromuscular disease, but with a certain prevalence in Quebec. Obviously, I'm interested on the impact of this disease on muscular system dystrophy, myotony, that will lead to muscular weakness. But we cannot put aside everything that deals with cognitive disorders. We know that there are executive functions problems, memory problems, certain forms of DM1 lead to mental to limitations, and it was a population also that I didn't know that much. I didn't know about this. Apathy is a feature, a trait, and it's a problem when you try to implement a training, a schedule, an agenda, and that's a problem when we think about, will the attrition rate be very high in that regard? And in doing so, we need to have a very high number of subjects to eventually train a very small number. More functionally, these people have balance problems, walking disorders. Despite this, throughout lifetime, they will be still walking, but they are exposed to an important risk of falling. More specifically for walking, Quebec studies showed the good relation between certain walking parameters. Talking about asymmetrics, space, time, and time parameters time being a limiting factor, these studies show this relation with walking, but walking analysis was done through only looking at the moving of the center of gravity. In doing so, we cannot have all kinetic parameters. If we look at the literature and in neuromuscular disease, it's quite a literature desert. There are only 3 studies that made a 3D analysis for that specific population. And however, they are not very satisfying with regard to the question we had in mind. One of the 3 studies really described the kinetic parameters when walking, but with only 10 subjects. Also, the Trembleur in Belgium made a good dynamic, electrographic, and kinetic analysis of DM1 patients, but there was only for a symposium and with limited results, and a past study only for the lower body, not measuring strength. Now, these physical limitations described for DM1 could also describe any other person with a functional limitation, reducing physical activity, creating social isolation, reducing then functions, and it is a deconditioning spiral. A deconditioning that we can define as a reduction of motor skills beyond what is initially created by the deficiency. So it is much in link with activities and could be reversible through activity. When we're talking about physical activity and rehab, aquatic activities as a choice, a prime activity, especially when we have a pool at the rehab center. Why is it a prime activity? Well, non-swimmers here know about it. It requires a lot of energy when you are trying to swim. It's a very good cardio activity. With certain parameters, we can reach certain intensity. If you put paddles on the arms, you can generate a certain amount of strength. And the water also, you can reach movement amplitude that are very interesting. Why are they more significant in water than on the ground? Well, in water you subtract the effect of gravity. Archimedes is helping you, and risk of falling also are reduced. Obviously, we need floating aids that are adequate, obviously. It is a context that is favorable. At Lucie Bruno, there is a aquatic program, especially for the Neuromuscular clinic. I met Maria Bocos, who implemented this training program, saw the benefits without measuring them. So we formalized a research project in order to assess the effects of that training on functionality on functioning, because when looking at literature, whatever the population, I look, for example, at cerebral paralysis, cerebral palsy, and we know that in rehab, aquatic training is really a prime candidate for a good activity. The objective of the study was to assess the effects of an aquatic training, a group aquatic training, on motor functioning for adults with DM1. Hypothesis, we were not very ambitious first because, well, in the end, these are preliminary data with regard of the number. We would say that aquatic training would be as efficient as training on the ground. Now I'd like to talk about the effects of training in the second part. But first, I would introduce the results linked with the sub-objective to study relations between levels of strength and walking for people with DM1. I'd like to talk about the methodology of assessment, which is the same in both studies. "22 DM1 patients were included in the study. Lucie Bruno Rehab Center to do so, well, is a great place to reach that threshold of patients, and this was very favorable to reach that N number for statistical purposes. Inclusion criteria: adults, a clinical diagnosis of DM1, and somebody who can collaborates, understands instructions, etc. Exclusion criteria: classical, to not have followed any physical training in the last 12 months before the beginning of the study. Obviously, no surgery planned during the study, and also no previous surgery 12 months previous to the study. Here we have the chart of the patients. I'm very happy to have these 19 people with DM1. If adult forms or intellectual deficiency, only 2 had more problematic ones. The design, experimental design, we have tests, learning how to test. They all came to the CRME walking lab as a pre-screening. This pre-test is where I link strength with walking kinetic. Walking testing, rehab testing also at Lucie Bruno. One group training in aquatic training, another one doing equivalent ground training, which is the base level, the classic training, and then post assessment. So pre-post, a very classic design. At Marie-Enfant walking lab rather, we can reach standard walking quantified analyses, meaning a kinetic analysis of movement, a dynamic analysis also of forces in play, and electromyographic assessment. And actually I don't have results on the electromyographic side. For this classical analysis, we asked patients to do a 10 meters round trip. You don't walk in a lab, of course, as you walk in everyday life, so we are asking shorter distances. Once the person did the number of round trips that was wanted, we want them to walk non-intentionally on this platform of form with the blue square. By the time we have 7 data, we apply a kinematic model to match external markers and the articulations to reach the real movements of the skeleton. Eventually, we end up with a kinetic result. We recreate the whole body, so the torso incline, the hip, knees, flexions, the ankle, so the torso, hip, knee, and ankles, and all 3 models, frontal, cross-sectional, and the other one also. Here's for the cinematic data. If we add force platforms, or we can reach the moment of strength on articulations. So reaching the role of muscles and movement, because here we're talking about internal force. Luckily, we have a big enough lab in Marie Enfant to implement a continuous walking path. Minimum 25 meters is needed. And doing so, we can have original protocols and following a walking kinetic during a continuous exercise. During that continuous exercise, what do we come up with? Well, it's not a 6-minute walking test as you know it, because the instruction we give to the patient is to walk at a comfortable walking pace and not to cover the largest area, such as is the case in a 6-minute walking test. Why? Because we need to test walking heart rate, not natural, but then eventually to reach normal walking heart rate. The average walking pace, sometimes we adapt it because some people cannot walk for 6 minutes. And then if we compare, then we take the average walking pace for a continuous exercise. For clinical tests, with Maria Vocost and one master degree student, it was held in Le Centre Marie Bruno. The time up and go test also to assess the capacity of a person to get up and walk a few meters and come back and sit down. It's a very representative and interesting walking test. Clinical assessments. Systematically, we do lower body portable dynamometrics, also manual muscle testing, and we had a double measure on muscular strength with the big limits relative to both of these instruments, of course. We handed SF36 quality of life and MHAVIE life habits questionnaires. Now moving to results linked to the walking analysis and pre-training on 22 subjects. Now I only have 19. What does this reveal? Well, people with DM1, I think we can recognize the clinical picture that is usually described, a trunk that is slightly tilted forward. In a small square, you have a walking cycle. The walking cycle starts when you plant the foot until you plant that same foot again, and that heel again. So you have the walking cycle represented. The trunk is tilted slightly forward during all of the cycle, the walking cycle. Also notice that for the hip, you have the sagittal plan, and you have the hip support, the green bar being the difference between support phase and balance phase. What we see is that a hip extension problem for DM1. With regard to knees, we notice that they have an initial contact that is more with a leg that is extended and that stays extended more than with a normal population. With respect to ankle, we see very characteristic things. For the first pivot on the heel, following the initial contact, we find what is described in literature. A foot that tends to tap on the floor linked to the tibia or the shin weakness. Then a dorsiflexion that is passive, and then a falling foot, a foot that stays. Really reaching in the clinical picture with this analysis, of course. A frontal model, very fewer differences. Maybe we can notice a little bit more abductions to have more balance, and these mechanisms also. Slightly an external rotation with feet. Slightly more an external rotation compared with normal population. Also to increase support, the support base. If we see relations between spatial temporal and strength, what we see is that the length of the step is conditioned by strength parameters. We see correlations here between the length of the step and extensors and flexors of knees, hips, and hip abductors. So, with the exception of knee flexors, which is close to a signification, we see that the length of step is really linked to strength. Ankle strength also. Ankle strength is is strongly determined to when transitioning from one step to another to maintain a walking pace. What appeared with regard to strength is that it was a reduced strength versus normal population, a strength peak that is very low for the ankle at the knee level. Very low variation of generation and absorption of power of strength, at least during the support phase. Why? Well, because the knee has very little movement. It is somewhat stuck in extension, because with low muscular strength, you cannot have this little flexion when you support, otherwise they would fall or collapse. Also, because having no action on triceps, they will not put the foot and knee flexion together. When walking, when I put pressure on the front of the foot, the ground reaction goes in front of the knee and bars the knees like this. And because they do not have triceps strength, they cannot implement this mechanism that is very important in the walking analysis. Now moving on a little faster here. If we look at linear regression models, what would be parameters explaining variation between length of walking or length of the step? Only the ankle power explained 57% of walking speed variation, which is very interesting. And strength parameters, we are not measuring ankle strength because of dorsiflexion, flexion, and extension, because measuring plantar flexion is very complicated and validity is somewhat contested, or the reproductivity of this measure is not very good. We rather looked at the strength of ankle as a proxy of strength, and if we look at the power of extension of the knee and force of flexion of the hip, it explains 74% of the variation of the length of the step. So we can target key groups to maintain a good length of step for DM1. Going further, cinematic link with strength, we see that maximum extension of the hips, the maximum value here you have in the first column. Okay, we don't see very well. The first column, a significant R at 0.47 is the relation between the maximum hip value, and the maximum hip value is located at the initial contact with knee extensors. Why? Because in knee extensors, there is also one portion that is bi-jointed and participates in the hip flexion, and the stronger they are, the more they can flex the hips. Moving on now to talk about, well, just to conclude on this first study, there are interesting relations between the strength level and walking skills. Now looking at aquatic training skills for functioning. The training in details. I started with a warm-up to wake up muscles and joints, then more muscular workout. The workout was installed per stations, with patients moving from station to station. One was on abs and abs training and trunks training, lower body strengthening, and we need know-how from the physical therapist to know what exercises to use and develop in aquatic training. Then the speed of movements with faster exercises, and then more of an entertainment part with a ball. Ground training, same objectives, same muscle groups. The intensity was similar with a certain limit. It's hard to have exactly the same intensity in ground and water, but we had the same objectives and we're targeting the same muscle groups. Moving to results now. We like to have curves meeting each other because it shows interactions of different trainings. What is noticed here is the significant difference and significant improvement of time up and go performance improvement with a reduction in aquatic, which we do not see in the ground group. Why the ground group? We see a higher variability. If we look at walking speed on the continuous walking exercise, for the aquatic group, these are individual results because there's no significant differences. We have varied groups. What we see individually is that there's nothing really clear-cut between both approaches, somewhat equivalent, but a slight improvement for aquatic that we don't find in groups, but this is non-significant. For muscle strength, does a better muscle strength explain that time up and go improvements? In manual testing, we see significant improvements of hip abduction, hip rotations. It's not really what helped them, but what more significantly maybe knee flexion and extension strength. With regard to questionnaires, we had a significant improvement for SF36 aquatic group with a nice improvement. Ground improvement also, but non-significant. We have smaller samples, obviously, with somewhat a variability, and it's hard to really show differences. With regard to life habits, may be somewhat surprising, but we report a significant difference of life habits, an improvement of life habits for the ground group, but not the aquatic group. Discussion, conclusions on this study of a small samples. We're only looking at feasibility. We cannot take these results. We need to be able to increase the n number to have a more statistical power and be able to generate more results. What we can see is that this variability goes through the know-how of Maria Vokos, who really implemented all of the working sessions with a master degree student.
So the concern that was expressed to me on attrition, well, on the 12 in the aquatic group, 4 was withdrawn from the study. Is it a specific problem for DM1? the aquatic environment is not pleasant for all for therapy, but it's not for everyone. But been told, as we do say, that there's a gain in strength as preliminary result in the inferior members. It's definitely beneficial, functionally speaking. Thank you for your attention. I wanted to thank the rehab centers, Lucie Bruno. It's a very interesting environment. Maria Bukos, who wanted to put in place this research. And the career also, new initiatives that allowed us to fund this research. I would like to thank all the members of my lab, in particular Maxime Gosselin, who worked a lot with Maria in the pool, and he was really in charge of the project. He could not be present. Benjamin, our research assistant, in charge of all the quantification of the walking data, the relation between walking and muscular strength, etc. Sorry for being a bit too long. Good afternoon. I have a question regarding the slide that talked about the strength of the ankle versus the speed of the walk. I was wondering, 57% of the increase of the speed was in function of the strength of the ankle. No, it's not 57% of the increase. We explain the variation that can be observed with the whole group can be explained in 57% of the cases can be explained by the strength of the ankle, by the question of the strength of the ankle. It's not an immediate link. We feel that it explains a good percentage of the variability. So if you have in the pool, if you use palms, could it increase the effect? Yes, certainly. More and more, the training sessions with adapted physical activities will be more with using strength. We won't. If it's to be functional, you need a speed of movement, and with more resistance, the more good effect you will have. Another question, you said that you are looking at aquatic training for cerebral palsy. Yes, we wrote an article on that, on aquatic training in this case also. There's not much, but there is one that we wrote. Good afternoon, Mr. Ballaz. Thank you for this very interesting presentation. It's very interesting to have a group with aquatic training versus classical training. It's difficult to have these statistics, but have you looked at the clinical impact between pre-post and after? We made an informal phone interview after the training session. When I prepared this presentation, Maxime sent it all to me, but I didn't have time to analyze it all. But we will have data on what people have felt from this training session. I do also want to look at that. We want to know if it was pleasant for the person, if it can be generalized. Yes, indeed. And with the data that you have, the time out and go, you can look at the speed. Are we talking about seconds, minutes? It could help us to know exactly the effect. on a score between 0 and 9, the researchers say that a difference of 0.5 is enough to see a clinical result, a clinical change. Yes, when we have little n's. It was very interesting. Last question, thank you. I'm happy to see that researchers are interested by the links between strength and function and the prescription of the exercise for DM1 patients. I'm not too surprised to see the result of the power, so much increase in the variation in the speed of walking. But I'm surprised of something else. Would you have, if you had pilot groups, it would have been interesting to see the results. We know that in DM1, it's distal at the beginning, but recently we have seen in studies that if we measure the strength well, we have deficiencies in strength, a measure of deficiencies of strength that are quite high at the hip level. And with certain patients, the loss of strength at the ankle can be compensated by what happens near the hip. So I'm a bit surprised to see that maybe you didn't have time to go through all your data, but I would be surprised to see what happens at the hip in your exercise program. Could it not explain in part what you have observed with walking? To answer the first part of your question, well, we go through open doors a little bit. Clearly, what strength is clearly important. For us in our lab, we really trust the strength we measure. We've been doing that for a long time. We have a big limit on these measures. Maybe we don't have the best practices still. For me, the measure is less of many evils. It's better quantified than with manual testing, but it's less precise than the ergometer. But I will remember what you are saying. It's a very new result, but I will look at our data with taking what you're saying into consideration. One last comment. I saw you had only 2 patients and 2 phenotypes. Do you think that if you had isolated the phenotypes, you may have had different results? Because we have seen recently it is a means to have a broader sampling to put various phenotypes together. But we've seen recently in the literature that if we put phenotypes together and we keep the level of deficiency with the late and adult cases, we have different conclusions if we separate them. And sometimes it's significant between the 2 phenotypes. Maybe it would be interesting if you would have had different conclusions. It would be interesting indeed. The congenital group, we could really have more homogeneous groups. But we have the dilemma. We want an N to have statistics result, and we want a clinical reality. We made studies where we look at fatigues of neuromuscular diseases. They were all suffering from fatigue, but they didn't have the same disease. But certainly, I'll look at that. Thanks.